Hey guys, Dr. Nickels here with a day with Dr. Nickels. So I wanted to talk about a couple of patient cases today that I thought were pretty interesting. So this gentleman here is a 42-year-old male that came to me with fatigue, insomnia, problems losing weight, some anxiety, and I did get some labs that his primary ran in January that, in my mind, were a little off. Fasting glucose was 118. His cholesterol was 127, which I thought was a little strange, very low. He's not on a statin. Triglycerides looked really good at 53. His healthy cholesterol was 45, which was good for, a gentleman, and especially with, a low cholesterol like that. And his LDL cholesterol, the bad cholesterol, was 71. So from a lipid standpoint, he was the epitome of health, even with a fasting glucose of 118, which I thought was a little strange. His hemoglobin A1C in January was 5.5. Prediabetes is 5.7. So that tells me that his average sugar in the bloodstream over the past 2 to 3 months was 111. Again, interesting, especially for the fact that his cholesterol was so low. Now, a 42-year-old gentleman, anybody who's 42, we see cholesterol increase from a production standpoint, and that's because of hormonal change. The liver will start producing more cholesterol to compensate for, testicular failure, ovarian failure. So a 42-year-old guy with a cholesterol of 127 was a little strange to me. So that's the stuff that I got from his primary. So I did my own testing, and it was really interesting because what we found was that now the other test was in January. So his lipid panel now showed that, where are they here? That his total cholesterol went up to 147. Triglycerides still decent at 85. His healthy cholesterol, 47, so that went up a little bit. His bad cholesterol, good at 83. But we know that that's just a calculated amount. So the lipid panel that I did looked at lipoprofile, looked at the particle breakdown and the actual number of particles and the particle size. And so his LDL calculated was 83, but the actual number of particles, LDL particles that he had was 1186, which was just slightly above the range. But then we have to look at, of the 1186, how many of them are small, and 580 of the 1186 were small. So he was making a lot of the small LDLs, and those are the ones that get stuck in the vessel lining and harden. So his true cardiovascular risk is actually about 60%. And nobody would have known because his lipid panel looks amazing. But this is where the importance of doing better testing, doing more in-depth testing is truly going to give you where your cardiovascular risk is. Nobody would think that he's a ticking time bomb, but he's kind of a ticking time bomb. And so ultimately, what drives the production of the small LDLs is insulin resistance and blood sugar issues. And his A1C back in January was 5.5. Now, I want to say it was 5.8. So now he is pre-diabetic. So it's the blood sugar that's driving the production of the small bad particles, which is increasing cardiovascular risk. But nobody would have known. So my point to bringing up this case is, just because things look good on the outside, doesn't mean that that's truly what's happening. And so if you're not getting results with, inflammation, feeling better, weight loss, things that way, you might have to get some other testing that's going to dive a little more in depth to really truly see what's going on. So I thought that was really interesting, and we'll see how things transpire over the next 6 to 8 weeks when I do a follow-up with him. So I thought that was really interesting. I have another patient that essentially I saw her this morning, and I wanted to bring this one up because I see a lot of patients who have had, who've been treated for things in the past, and their symptoms never went away. So ultimately, wait, this is the wrong one. Well, anyways, this patient was, all right, so this patient saw me, she's been seeing me for a while. She came in with oral lichens planus, and so really at the end of the day, she had fungal infection of the mouth, and she came in to see me for her yearly follow-up. And so what was interesting is she's been having urinary urgency, frequency, and that kind of comes and goes. She is essentially, let's see how old she is, 74. And when we treated her oral lichens with antifungals, the urinary urgency, kind of went away. She was treated for a skin infection in spring and was put on antibiotics. And she's been having urinary urgency. And so I asked her, I'm like, well, what happened to the urinary urgency when you were on the antibiotics? And she said that it went away when she was on the antibiotics for her skin infection. So I say that because it's not coincidence. It's because what's triggering the urinary urgency is probably a low-grade UTI, a bacterial infection. So today I did a urine culture, and we're gonna set, or a urine dip, and I'm gonna send that out for a culture and sensitivity. But the leukocytes were showing something positive, so she could be having low-grade urinary tract infection. So I bring this up because if you're on antibiotics for something totally unrelated to some of the symptoms that you're having, and your symptoms go away, then it has to be bacterial related. It's not coincidence. So then you have to kind of take a step back and say, okay, well then we need to look down that path or that road and investigate that a little more, because it's not coincidence. I had another new patient that came in last week, and she was diagnosed with a kind of a rare autoimmune disease, and she was treated for chronic Lyme disease. She was on antibiotics for a year. Her symptoms never got better. That's another thing too. If your symptoms don't get better and you think it's infection related, it should get better within a couple days. It doesn't take weeks to months. So again, kind of food for thought. If you're on a medication for something totally, totally random in a sense, but it fixes some other symptoms, then you have to take a look at that, and it is bacterial related. Or vice versa, if you're on antibiotics for something and it doesn't get better, well then it's not bacterial related. So I thought that was very interesting too. So kind of, again, you gotta have to take a step outside the box and kind of think of things and bring that up to your doctor, and then try to go down the right path. So all right guys, until next time, talk to you later.